Thank you for everybody that showed up today. And every Thursday of each month, we hold this webinar series. And it's basically designed to spotlight those resources in rural healthcare, especially across Utah, or specifically across Utah. Our aim, though, through RHAU is to improve health outcomes by increasing our awareness and encouraging those to use the tools through the connections that we offer. And everything's going to be recorded, as Casey said earlier. And again, just grateful for everyone that joined today's session. And then for the agenda today, we're going to get into, we'll have two speakers scheduled for this session. The first one is Dr. Rachel Ware from the Consultation Access Link Line to Utah Psychiatry, or Call Up. That's housed at the Huntsman Mental Health Institute. And Dr. Ware will be discussing the history and expansion of the Call Up program and how to access and utilize the tools. And then after Dr. Ware's presentation, we'll be with Zach Jensen representing Aspire 365. And I believe Zach will be presenting with another speaker as well. So the innovation telehealth-based program that provides mental health, substance use, and preventative behavioral health services. So each presenter, as Casey said earlier, will have 20 minutes to present and then a 5-minute Q&A at the end of the session. And all this is being recorded so that we can put it on our website as well, so other people can view it. So I'm going to do a little background for Call Up and Rachel Ware. Rachel Ware is a clinical associate professor for the Huntsman Mental Health Institute and the chief of mental health integration for the University of Utah Health. In this role, she oversees a variety of efforts, including those that improve mental health screenings, follow-up, and access to care for patients with depression. She helped found Call Up, the statewide child psychiatry access program, and also serves as a psychiatry lead for implementation of the collaborative care models in primary care across the University of Utah Health. So Dr. Ware, if you are ready, the time is yours, and we'll go until 12:25 for your presentation.
Great. Yes, thank you, Lex. You can advance to the next slide.
Yes.
Thanks for giving me some time today. So this will be what we'll cover today. We'll talk a little bit about the history of Call Up, our current expansion, and where we can potentially help you and some of your other rural partners and clinics, and then just a brief tutorial on kind of how to use it. So go ahead. Next slide. So I'm sure you're aware of a lot of these statistics, but we really struggle as far as mental health in Utah, but both with high prevalence of illness and higher suicide rates in youth, as well as low access to specialists. So this map here really details counties in Utah that do not have access to any child psychiatrist at all. So all of the counties in red have 0 child psychiatrists. You can go to the next slide. So we, a few of my colleagues and I at the Department of Psychiatry at HMHI were kind of involved in how do we really expand our reach into like primary care and further corners of the state and maybe even outside of the state, and started looking into some options. And one that we learned about really early was these call-in lines for child psychiatry consults. And these had taken off nationally about the time we were looking into this, about 2018 and 19. So this started on kind of the East Coast, but by the time we got our program, about 20 states had some type of psychiatry call-in line. So we, the state legislature appropriated the funds, and then there was an RFP process, and HMHI was, well, Uni at the time was awarded the funds. So we went live in 2020 with our program. Okay, next slide. What we are is basically just what I already described. We started as just a child psychiatry call-in line. So basically any primary care provider, whether or not that's a physician, APC, who has a clinical question about a child or teen, and actually up to age 24, because that's where we found that we could have the biggest impact potentially with the high suicide rates in individuals up to 24 in our state. can call into this line and get a consultation over the phone from a child psychiatrist. So we get a lot of diagnostic and medication questions, but we do take calls about coordinating care, crisis services, therapeutic intervention. So we do have opportunities to consult on more than just medication questions. So to date, this is the number of consults that we've done. We also have done a number of educational webinars that are free and available and provide CME to anybody who would like to watch them. They're often a combination of pediatric mental health topics as well as things like how do you implement behavioral health integration into primary care successfully. So we've gotten consults from this many counties in Utah, all the ones in green, still waiting on a few, but our reach has been pretty good. And when we have surveyed providers, they've said that this program has helped their confidence in maybe making that right decision, particularly about medication, especially knowing that they can contact us again if they have a question. Okay, next slide. Just real quick, just provider feedback that we've gotten on, some of our survey results, but themes there seem to be, fast access, being able to offer some good advice on next steps. Next slide. Okay, expansion. Next slide. So what we have found is despite, presentations like this, despite having presenting at health fairs and things like that, and actually direct outreach to primary care practices as well. Just awareness and utilization of the service sometimes struggles. Once people start to find out about us and use the service, they're very happy and they tend to, come back again. But it's kind of that initial engagement with what we've struggled with. Now, I mentioned there's a lot of these programs around the country. Most of them actually got federal funding, not state, to get started. So since we had the state funding first, we were looking into if we could potentially get some federal funding to expand. And we did that through HRSA grant, Health Research and Services Administration grant. Yeah, I believe that's it. That funds a lot of these programs for individual states in 2023. So that allowed our expansion. Next slide. So this is what our expansion kind of looks like. And I'd invite anyone who's, watching this after the fact, if you have interest in any type of pilot with us or any of these expansion categories, please reach out. So original call up was designed more specifically for primary care. We want to expand that now into emergency departments. As you know, there can really be a problem with kids and teens and adults, of course, but boarding in emergency departments while they're maybe waiting for a crisis assessment that they can't get, or someone to safety plan with them so they can safely go home without patient follow-up, or they need a bed available. And then schools. As you're probably aware, there's been a lot of attention to schools likely being a very effective place to intervene early for mental health concerns for kids and teens. We've also added a case management role, and I believe, I'm not sure if Lily is on the call, but she's our case manager for the program, and she can help patients connect to services or treatment in the community after we've done a consult. Or sometimes that's the only question is, can you help connect this patient to care? Okay, next slide. So what we've done as far as increasing our access, we've expanded our hours. We initially, with the funding we had, we could only cover a shorter period of time, but now we have just pretty much full day coverage, Monday through Friday. We do have an option if any of you use in your rural communities use e-consults or electronic consults to specialists. We have a platform for that as well. So if you have busy primary care providers in your practice and you think, gosh, they can't ever get on the phone, they are able, like after hours, like when they're charting at the end of the day, they can send us in a clinical summary of a patient and a question, and we can respond to that through that asynchronous platform. We have more echo modules like those webinars and clinical topics that I mentioned, and then collaborative care, which I'm going to get to. The emergency department pilot is being developed right now. And then we also have an echo clinic for a lot of our school personnel. So instead of just directing the focus to primary care providers, now we're looking at teachers and people that work in schools, as well as emergency departments, and really mental health professionals as well. So if you have maybe psychiatric APCs in your clinic who potentially want consults on their patients from time to time, or even therapists, and therapists can be a great connection for primary care as well. Okay, next slide. Okay, so since Lex mentioned that my work largely has been around mental health screening and collaborative care, I wanted to just touch on collaborative care for a minute because we do have an opportunity to help primary care practices anywhere in our state implement collaborative care. So these are the main principles of collaborative care. This is a primary care program, and it is the most effective, at least in terms of looking at the research in terms of patient outcomes and improvement for sure. It provides the fastest access to care and has the best clinical outcomes. So these are the kind of main principles. If you can go to the next slide. This is the team component in collaborative care. So like in usual care, in primary care, you'd have your patient and maybe their family, if we're talking about a child and teen for sure, and the primary care provider. What collaborative care adds is a behavioral health care manager, and that person can be in a number of different credentials. It could be a nurse care manager in your clinic. It could be a licensed clinical social worker or a professional counselor. And then you add a psychiatric consultant as well. And that can be an MD like myself or a psychiatric APC. Okay, next slide. These would be some of the reasons for practices to implement COCM. The billing for COCM, collaborative care, is very unique in that it still comes out of the medical benefit. So many of you are probably aware about all of the behavioral health payer limitations, such as behavioral health carve-outs. Often even if you put a therapist in a primary care clinic or a psychiatry APC, they can't even necessarily take the same insurance that the primary care providers can. There can be some limitations there. Also, patients tend to have kind of higher copays and out of pocket costs. So this program, it's built out of the medical benefit and all of the things that tend to benefit people that we often don't do because we don't get paid for them, like coordinate care, like have team meetings with a psychiatrist, therapist, primary care provider. That's all reimbursable under COCM in one copay that's done based on the number of minutes per month. So it's much more affordable to patients. It provides better outcomes. You don't necessarily need to credential your behavioral health providers under all those behavioral health payers, like I said, because this is just billed as incident to the primary care provider. It's also this is just the financial. I could go on and on about the clinical advantages, such as improved patient outcomes, pretty much immediate access to care, all care in one place. But this is just kind of the finance side of why a practice might consider this. The disadvantages there can be some startup costs with training, building a registry, and hiring, especially that BHCM role. So that's why with Call Up, we have an opportunity now to help practices train that BHCM, provide some support, and even provide some psychiatric consultation as you're starting up at no charge to the practices, maybe for about 6 months, maybe 12 at the most. Okay, next slide. Using Call Up. So how would it work if your providers want to call in? They just call the number that is listed kind of all over the webpage and was on one of those earlier slides. Our contact center agent will kind of get some basic information and put in a request for a psychiatric consultation, and your provider will either get a call back if they wanted that to be a typed consult. They can state that, and that will get completed. But we're basically able to get all these completed within 24 hours. Next slide. Again, these are our hours. That's the phone number. That's the online portal if you wanted to do an online consultation. And this is our Echo series that I mentioned. So basically every Thursday at noon, with the exception of schools that likes to meet a little earlier in the day, we have these educational topics that your providers can register for. Ask questions. I lead one that's on collaborative care implementation specifically. It's a 6-month series. And just like this, these are all recorded. So if you can't make it 12 to 1, you can watch all that after the fact. You just can't get CME after the fact. Okay, next slide. I already kind of mentioned this, so this will just be a reference. Next slide. Again, that's part of the CME. Okay, so this is our team. These 6 physicians on the left all work for HMHI in different contexts. I'm going to roll through them really briefly in a second. That third column there, these are our 3 psychiatry leads for the program. I'm one of them. And then our far right is our amazing support staff. I think you guys mentioned Lauren, Jocelyn Romano, who works specifically for the HRSA grant expansion, and Lily, who is our amazing care coordinator. Okay, next slide. These I'm going to mainly leave in here as a reference for you, but what we try to do with our 6 psychiatry leads is anyone can call any time of day and speak to a provider. But in addition, we assign some regions to our psychiatrists. So if you're in one of these counties, Dr. Anderson could come and do a meet and greet, probably through Zoom, but he could do it, with your providers at, over a lunchtime or a provider meeting or something like that. They could contact, Dr. Anderson directly after kind of forming this relationship, with him specifically. Some of our clinics requested that so they don't feel like they're just kind of calling an anonymous number. Next slide. This is Dr. Black and his interest in the counties he's associated with. Next slide. Dr. Chochel, more kind of northern part of the state. Next slide. Yeah, Dr. Lynn, she has a lot of experience in bipolar disorder. And those are the counties she's associated with. And then I think our last provider, oh no, we have 2 more, sorry. Dr. Pagel, she does a lot of work in schools already. So she's a great contact for any school-related mental health. And those are the counties she's working with and actually lives in. Next slide. And Dr. Smith, he works at the Children's Center. So this is like the preschool program for young children with, really difficult early onset mental health problems. So age 2 to 5. So those are the counties that he's associated with, but also any really early childhood consults, we direct to Dr. Smith. He has a lot of great experience. The next slide. And this is Lily, and Lily is also available full-time. Again, that care coordination piece for families, connection to resources. Lily is happy to reach out and contact those families. We just need, when you reach out to us, let us know that, you know, we have permission to kind of contact the families, that they said yes, they would like that. Okay, next slide. I'm going to kind of go through this pretty quickly, just because this can be in here as a reference, but this is basically what the platform looks like. Next slide. You'd have to sign up once, then basically each provider would get, you know, a dashboard where they can see if they're getting a response about their consult. They can see the status. If they don't remember, oh, I think I got a consult on that kid about a month ago, they can go back in and look at what their response was. Next slide. Yeah, more kind of informational. Next slide. Yeah, and this would be just the contact center. If your providers call in, this would be a lot of information that the contact center enters for them. Next slide. So this is my last slide, and this is where I would really welcome any type of feedback, or for people to reach out to me or Lauren. As you mentioned, you guys have a contact with Lauren Brown. But one opportunity that we've thought of, because we do know primary care providers are so busy, would be, you could have a contact like one medical assistant or front desk staff, or maybe even the clinic manager, serve as the person that's going to put all of these consults into the system, or call in with them and then say, Dr. So-and-so is, you know, available. This is the kind of short story on the patient. Then you can put in all of the information. The contact center agent will put that in, and then you can say, Dr. So-and-so is going to be available today, you know, from 4 to 5 while they're doing their charting for a call back. And then you don't have to burden like your providers who are seeing patients so quickly with, you know, calling in to put these consults in. They can just wait for the call back. Another opportunity that we've thought about that I think could really appeal to some of our rural practices would be doing some type of like group supervision or case consultation, especially for providers that are working in behavioral health integration. I love behavioral health integration, working in primary care as a mental health professional. I love the team-based approach. But it can be a little bit isolating if you're the only mental health professional in your clinic. Everyone else is kind of in primary care or has different roles. So, you know, we'd love to put together like a peer supervision group for some of our behavioral health professionals that are working in these settings, just as an opportunity to, you know, discuss common problems that they see, maybe even struggles with things like patient engagement and how to create access, but also individual patient cases. There are opportunities to bill for your providers to bill for using this service, for calling in. We'd love to get feedback from you and anyone on your team. I think we're going to be working on a survey, how we can increase the utilization and what ideas you might have to make it more effective and valuable. And then, like I mentioned earlier, if you have practices that are maybe at the beginning of implementing collaborative care, or are thinking about it, we can help you with behavioral health care manager training. I'm currently leading that implementation on COCM Echo webinar right now for 6 months. But after that, we're looking at kind of doing more of an advanced, like a peer supervision, you know, type of monthly group where we kind of get together and talk about some of the issues we're struggling with. And then, like I said, if your practices, maybe they don't have any psychiatric consultation at all, or maybe they do have a psych APC, but that person hasn't really worked in collaborative care, and you want some like psychiatric expertise to just get things up and rolling and get like your psychiatry APC trained, so that you can offer this to your patients in part of that stepped care model. We'd be happy to provide that as well. So I guess I don't think we put like email addresses on here, but I'm happy to get that to whoever coordinated this when you guys send this out with the slides. And I think you have a contact for Lauren as well. Next slide, I think, should just be questions. Yes. So I know it's a small group, but does anyone have any questions or comments? Okay.
Thank you. Appreciate
Of course.
that. Okay, perfect. All right, thank you, Dr. Ware, for sharing those critical info about the call-up program. And then again, the slides from our presentation, they will be available on our website. So if you do want to shoot us an email of any sort, we can get that attached. But for our next presenter, Zach Jensen, with Aspire 365, Zach and his brother Keaton and father Steve are the founders of Aspire 365. Building off of Steve's experience managing inpatient substance use treatment centers, Zach and Keaton have spearheaded the development of this innovation model for at-home substance use treatments that approach SUD as a chronic illness. They have grown their program in partnership with groups like Johns Hopkins University and the Drug Enforcement Administration, and are now offering service across multiple states. So from 2019 to 2022, Aspire 365 participated with RHAU and in Rural Community Opioid Response Program Implementation Grant. That was a big one. Where they were able to demonstrate the effectiveness of their program across Kane, Garfield, Wayne, and Paiute counties. Zach and his team have grown Aspire 365 into a robust and impactful program, securing insurance coverage across multiple major insurance providers in Utah. Thank you, Zach, for being here today. You'll have time until 12:50. So time is yours. Start whenever you're ready.
Awesome. Thanks, Lex. Can you hear me just fine? Awesome. Dr. Ware, first presentation was fascinating. I think your call-up program is super cool. I don't know why we haven't heard this before. Obviously, we're dealing in some of the same arena, Dr. Ware, and we've seen, as we've expanded programming, access to care for mental health services is very, very limited, especially, as you pointed out, specifically for our adolescents. Services are very, very limited. And so to be able to deliver access to care and provide care in a chronic structure, we've designed kind of a unique program. We've been around for about 7 years now. It's a little 7.5 years. We operate in 13 states now, Keaton, and then we're expanding to 2 additional ones this quarter that'll go live. We've been in Utah for a period of time now. As Lex mentioned, we worked with in our southern Utah communities for 3 years, running a federal grant that was incredibly fun and very, very successful. And that was really a catalyst for us to start expanding across the country. And so we've loved working in southern Utah and supporting our people and markets there. To give you just a quick overview of what Aspire 365 is, we are an in-home behavioral health program. We provide structured programming for mental health, substance use, as well as preventive behavioral health care. Go ahead to the next slide, Lex. We deliver services in a fairly unique fashion. Every client that comes into Aspire Services is assigned a 6-person team. That team includes a psychiatrist, and a nurse, an individual therapist, a family therapist, a case manager, and a support staff member. That can be a peer recovery coach or a life coach. We also wrap in family support services, particularly for our adolescent clients. I should mention that we do work with adolescents and adults 12 years old on up. So for our adolescent clients, we have a family support specialist that works directly one-on-one with the parents and siblings of our client outside of engagement with directly with the client. They do psychoeducation. They help the parents understand the conditions and how they can best help support their son, daughter, child. One of the components of the program that is paramount to how we deliver services is the length or duration of programming. So this team that you see on the screen that's assigned to each of our patients works with the patients one-on-one, as well as coordinating in the background internally to make sure the patient is getting the proper care and that care is coordinated effectively. We work with our clients for a baseline of 12 months. We've found in the last 7.5 years, plus some data from a team that we work with closely at Yale University, that behavioral health, mental health, substance use are chronic conditions. They take extended periods of time to ameliorate those conditions and symptoms. And so we work with our patients for that extended period of time, 12 plus months. We treat all conditions, all mental health conditions. We work with eating disorders. We work with, to a certain level, cognitive disabilities, and then all substances. And so we do work with a broad range in the behavioral health space. For our reach, and maybe go to the next slide, Lex, and we can kind of chat about access to care. Dr. Ware touched on this beautifully, and I think this is so critical to understand is access to care is very limited. With the infrastructure that we provide or have designed and built within Utah, we cover the entire state of Utah, and that includes our very rural communities here. And that with that, we operate underneath contracts with Select Health and Humana. We are Select Health Commercial and Medicaid. Finalizing Medicare there, and then we work with Humana Medicare here in the state. And so when we talk access to care, we work in areas, including Southern Utah, where we have wait times of 6 months. We have some states we work in where you want to see an adolescent psychiatrist right now, and the wait list is 18 months to get into an adolescent psychiatrist. With our programming, you can see here the wait times for patients to get care. So we do onboarding same day. An individual calls in, they're referred to us from a hospital, they're referred to us from their insurance partner, their primary care physician will call and make a referral. They will meet with somebody that day about an admission. They'll understand the program, and then we could go through the onboarding process if we are the correct fit for them. They'll meet their case manager the same day. They will meet their nurse within 48 hours, and then they'll meet with their psychiatrist no later than 72 hours. This includes our adolescent patients. Historically, as a program, we operate at 2.5 days to see their psychiatrist, which is, as Dr. Ware pointed out, pretty unheard of. We integrate their therapist and their family therapist and their support staff member during the duration of the first month of care, so they are getting that engagement. They'll meet their entire team before 30 days. That ensures that patients, especially discharging from a hospital, especially discharging, who need immediate access to care, have it. They have a team, they have support in place, and they have a schedule. And so we operate on a baseline schedule, and we design the programming based on their needs and conditions. Lex, if you want to click to the next slide, I'll kick it over to Keaton. He can talk about some of the metrics that are critical for our programming and some of the outcome measures that we track on a regular basis. Go ahead, Keaton.
Yeah, thank you so much. So when it comes to some of the areas we focus on and some of the data that we gather, you'll see here continued engagement rates are really important. What we found is that those who engage get better. It's a pretty straightforward statistic, especially mental health. Honing down these statistics, this one is very clear and concise. Where we focus and what we succeed in is our 90-day continued engagement rate. We focus on 180-day as well as our program completion. And funny enough, these statistics are a little bit off. This data is a little bit old. Our 90-day continued engagement rate at this point, as it pertains to the life of the company, is 93%. Our 180-day continued engagement rate is 80%, and program completion is right at about 70%. And so jumping to the next slide here. Oh, and one thing to mention as part of that there, as was mentioned by Lex and Zach, we did a grant that we participated in that grant in Southern Utah, and over the 3 years, we actually saw a completion rate of 91% for all those participants in Southern Utah in those counties. The other set of data here is this is covering a 200,000 appointment record data set. One of the things in our area where we focus and succeed on is our HEDIS measurements, meaning individuals being discharged from hospital, having access to a psychiatrist with a follow-up and a therapist with a follow-up within a parameter of time. We meet that measure 97% of the time. When it comes to reductions in anxiety and depression, within a 7-month span, is our average span in participation in the program, we see a 35% reduction in depression and a 50% reduction in anxiety for our patients. Our session attendance engagement, it actually showing up for their scheduled appointments, is 93.2%. And then you'll see over this bottom corner here at our reduction in utilization for hospitals and emergency care. We did a 3-year study aggregating data from 1 year prior to an individual admitting into our program, 1 year during, and then 1 year following. And this is something that we did with our insurance partners. And what we found is that individuals entering our services, once entering our services in programming, we reduced their utilization for behavioral health admissions to an emergency department or hospital by 97%. We reduced their admissions for any reason whatsoever to a hospital emergency department by 73%. And following our care and discharging out of our services for the following year, those numbers remain consistent across the board. Next slide, please.
Yeah, thanks, Keaton. So the last thing we want to touch on is our preventive processes or programming. One of the things that's offered to all Select Health members and all Humana members in the state is a mental health checkup, is how it's marketed. It is an annual psychiatric screening exam. Individuals can go to our website, they can schedule an appointment, they can scan a QR code that are in the schools or in offices around the state, and schedule a mental health checkup with a behavioral health technician. This process is very straightforward. It's for individuals ages 12 plus. It doesn't cost anything. Again, with our services, all of our services being covered by insurance outside of deductible and co-insurance, we have a monthly copay for all services rendered. This product is no different. So this is seated as preventive care. And so there is no copay with it. There is no cost to it. The way this structure works is individuals who access this service are taken to, once they schedule, they're taken to a self-administered screen. And that self-administered screen takes about 5 minutes to complete. Ask them ask the individual questions about their mental health, behavioral health concerns. The results of that self-administered screen are given to the technician, and the technician will have that resource at their disposal, along with the scoring from that self-administered screen for the actual virtual consultation with the member or the client. So if Dr. Ware was to schedule an appointment for tomorrow at noon to have a mental health checkup, she'd fill out the self-administered screen, and then tomorrow at noon, she would get on with one of our behavioral health technicians, go through the results of that screen. The consultation takes between 15 and 30 minutes. And from that screening process, we have a very good preliminary diagnosis for the individual. We know what level of care would be an appropriate fit for them and can make recommendations for navigating the behavioral health system. Additionally, the value of this product is that an individual that is screened that needs immediate services, they can be enrolled in Aspire services right away. And so this product is available again throughout the state. It's covered fully by those two insurance partners. And again, we're happy to provide any additional information on how to access these services to the group or any individuals after the call. But I think that covers it, Lex. If you want to kick it over. Again, small group, probably not any questions, but if you have anything, we're all ears.
Thank you again too. That was awesome. I think it's insane the retention rate you guys have now, getting into, I think you said 90% when they continue through the 90-day program, or not program, sorry, but yeah.
You got it.
Okay.
Retention's very high compared. It might be the fact that they're at their home and we know them where they live and they can't hide.
Yeah, hide from you.
Yeah.
I think one of the other big contributing factors is the way that the Aspire 365 programs delivered reduces a huge stigma barrier, like in these rural communities, to go to like a therapist's office in your community. When people see your car outside, they know you're there, they're gossiping. But the way that this model is delivered, it completely cuts all of that out, because they're in control of who knows that they're getting services. Yep. And I think that reduces a significant barrier in stigma that exists still in culture.
Yeah, agreed. Like the idea that, individuals can get full servicing while going to work, while going to school, maintaining their job and their family time, is a big value add, which is one reason I think that Dr. Ware's initiative that you guys are doing is just so valuable, is the ability to engage with people so quickly where they're at, especially at that primary care setting, before things escalate and we have an adverse event or a high cost acute event. Yeah, very powerful
difference for sure.
Yeah, but thanks for having us, you guys. This was awesome. We love engaging with you.
Yes, and it's nice to get this out to those in the rural communities. But I just wanted to say, from me and Casey's standpoint, thank you again to the speakers and everyone that attended. And then, as I said before, it's every Thursday, so next June 5th, it'll be at noon again. And our presentations will be from Utah State University Extension Program, and they will discuss the USU to be land grant institution for Utah. And then the second one will be a variety and structure of the USU Extension Program. So the presentation will also highlight the Utah Marriage Commission, which is one of the many USU Extension programs. And then if you wanted to RSVP for this, you can scan the QR code that we have on our screen currently. If you are interested in anyone that's watching this, besides, the recording will be available at our website. And then let's see a note. We are also currently accepting applications to be a presenter in the future sessions. So if you want to access the application from our website, we hope to highlight to many of our resources here in rural Utah. But thank you again for attending, and I think that'll be all for today.
Awesome. Thanks, guys.
Yep.
Thank you, everybody.
Thank you.
Good to see you.